Thank you, Madam Chair. My name is Trias. I'm from Universitas Airlangga, Indonesia. I will talk about nutrition education to prevent triple burden of malnutrition. If you look at this graph by the UNICEF, that 1 in 3 children around the world are suffering from malnutrition in any form. Could be wasting, stunting, or overweight. And this is the data in Indonesia from 2013 until 2022. We have a good progress in terms of declining the underweight and stunting, but we still have some work to do, especially related to stunting. The target from the World Health Assembly 2024 for Indonesia has to be 14%. And in last year, we still have 21.6%. So if you're working with the Indonesian government, all of the agencies in Indonesia are directed to overcome this stunting problem for under 5 children. And what is triple burden of malnutrition? It's actually a coexistence between protein, energy, malnutrition, the forms of stunting, underweight, or wasting, along with micronutrient deficiency, like zinc deficiency, selenium, iron, and others. But at the same time, we have an increase of overweight and obesity. If you look at on the paper, it could be in a population, in a country, a district level, or in a household level, where many of our work is related to household level, where one part members of the family are getting overweight and obese, but the kids are underweight or stunted. So many of the countries actually suffering for double or triple burden of malnutrition. And one of the leading expert in nutrition transition, Barry Popkin from University of North Carolina, proceeded this nutrition transition models where there's a pattern. Doesn't have to be in chronological order, because in many developing countries, sometimes the diversity are very huge. One of the populations, such as the urban population, they might already in this chronic disease phase, where many of the people are getting overweight and obese and have non-communicable diseases. But in other part of the country, we might still have hunter-gatherers, like people who really depend on the food availability from the nature. But then we have COVID-19, we have a disruption of production, distribution, and also consumption, where people are not easy to move around. So I posited that could be a twofold. It's like a double-edged sword, where people can be more prone to overweight and obesity because of lack of physical activity, because they have worked remotely. But in other setting, when the person are well aware about this importance of physical activity, they might move from what we call as obesogenic environment and live away from the obesogenic environment. But they can still work remotely and also embracing the healthy lifestyle. And the last pattern, the behavioral change, is something that we want to in the later stage. So what are the effects of triple burden of malnutrition? It's actually a life cycle. It begins with pregnant women. So mothers who are not well nourished, they can also make the future babies during the differentiation. They have what we call a disadaptation, where they have less support of nutrition. They will adapt to the scarcity of nutrient, but then when they grow old, when they become adult, they are more prone to non-communicable disease, because their body adapt for very effective metabolism. And for the children and also adolescent, the problem is related to stunting. Is about what we call intergenerational problem. They have less cognitive function. Then going to be not competitive at school. So in the result, they will have less professional salary because they can compete with others. So when this happens to a woman when they get married, there's numerous evidence published in the paper that short stature of women increase the risk of stunting about 2 to 3-fold. This is what have been promoted by WHO, which are what we call it, embraced by Indonesian government for nutrition-specific intervention ranging from anemia screening, consumption of iron folic acid, antenatal care, and also growth monitoring, exclusive breastfeeding, and some other direct interventions such as immunization and also nutrition education. Our study focused on this, what we call triple or double burden of malnutrition. Why? This is one of the study from the Latin America, I think it's from Peru or Mexico. And we see here that the double burden of malnutrition predominantly high in the middle income, those with middle household consumption. Not the poorest one and not the wealthiest one. But when we talk about stunting, of course, it's more prevalent on the low income. And our study also support this hypothesis. We have around 700 mothers and child pairs. It was done in urban setting in Surabaya, the second largest city in Indonesia. We recruit around 50 households 50 households in each sub-district. In total, we have 700 households. And our study also shown the yellow colors that even a mild insecure is already prone to have, we call it SCOUT, is stunted child and overweight or obese mothers. And when we do multivariate logistic regression, when we talk about stunting only, when the household are severely food insecure, they have increased the risk of child stunting almost twofold. But when we look at the double burden of malnutrition, even mild food insecurity already increase the risk of having stunting for children and overweight and obese for the mothers. So with this study, we know that double burden of malnutrition is not about the problem of food insecurity alone, but also how they choose their diet. And the other result of our study also been published in the journals, and we see here dietary diversity also matters. The more diverse, the likelihood of food insecurity is also what shall I say, like a negative correlation. So the higher the diversity, the diverse food, then the food insecurity is also more secure. And then following that cross-sectional survey that we do as a baseline with the 700 households, we do an intervention study. It's a nutrition education intervention based on socio-cognitive theory by Bandura. We have our comparison as a control. They receive visual care for 36 households, mothers and children pairs. And our intervention is a nutrition education along with home visit by the health workers. We did the intervention for 3 months. And what we did with nutrition education predominantly is improving self-efficacy. What we do is with mastery experience, we train them to do healthy grocery shopping, how to prepare food, because the problem is not only preparing more animal protein for the kids, but also fruit and vegetables for the mothers. And then vicarious experience, we do some games, peer group support, and also verbal motivation given by the local leaders or cadres to the mothers. This is some of the nutrition education that we do. It was done every 2 weeks, and every other week the cadre will go to the house of the mothers and child. And one of the problems is overweight and obesity, so we also promote physical activity. And this is a typical Indonesian, what we call it posyandu, monthly monitoring post when people do the registration, and then we have child monitoring, anthropometric measurement, and then we had supposed to have nutrition education or counseling, but due to lack of resources, sometimes it's not work. And then we have clinical services, especially immunization. Our studies show that there was an increase in height and weight of the children, but unfortunately not for the mothers. The waist circumference and also the weight is not significantly decreased. But for a behavioral outcome like self-efficacy barriers, self-efficacy tasks, all are pointing out into a positive direction where our intervention can improve the self-efficacy. And we believe that if we have more time and we have more budget, I think we will see a difference in terms of child stunting status, because only 3 months is not enough, I think, to change the nutritional status of the child. And this is what we currently doing for the overweight and obesity, because in urban Indonesia right now we can easily order food through a mobile application. We got like GrabFood or GoFood. Maybe many Southeast Asian will know this. Unfortunately, they don't have nutrition information in it. So we make this application. We can just take a picture or scan the food, and we put the database, so people will have this traffic light diet, if you will. So if we have to limit, then it's going to turn red, and yellow and green is okay. So with this, we hope that in the future it's also become a tools for decision making when we choose our food. Thank you very much. Arigatou gozaimasu.
Thank you very much.